Hello. In this webinar, I will try to illustrate how we try to move on toward precision prevention in the field of sport injury prevention, as well as in physical activity for health enhancement. Well, there is extensive evidence on the health benefits of running. And running is also one of the most popular forms of physical activity. This is why running has been suggested as a key lifestyle medicine for longevity. Here are some pieces of evidence on the health benefits of running. This graph on the left shows the cumulative and independent benefits of running and other physical activity on all-cause mortality. And you see that among active people, runners have a lower risk of all-cause mortality. On the right, the forest plot illustrates that whatever the sex, age, or other factors, the risk of all-cause mortality and cardiovascular mortality are reduced with running. And the estimates are quite impressive. The decrease in mortality can be translated in an increase in life expectancy by 3 years. The main drawback of running is the risk of injury. And the proportion of runners that will sustain an injury over the year can be up to 80%, depending on the population. This burden is of particular importance since injury is the main reason for people to stop running. How can we prevent running-related injury? May the prescription of appropriate running shoes be an efficient approach for injury prevention? We should first wonder what are the key shoe features. And the systematic review on studies that investigated running shoe features identified 28 of them. Which of these shoe features really matter for injury prevention? It is a common belief that foot posture is related to the risk of injury in running. In summary, supination refers to ankle leaning outward with a high foot arch, while pronation refers to ankle leaning inward with a flat foot. So in this study, we wanted to investigate if shoes equipped with a motion control system influence injury risk in running. Based on their foot posture, about 400 regular runners were randomly allocated to one of the study groups. In one group, they receive a pair of standard neutral shoes, and in the other group, they receive a pair of motion control shoes. We observed that in the whole group, the risk of injury was lower in those who received the shoes equipped with the motion control system when compared to those who received the shoes with the standard neutral shoes. Is this motion control system a one-fits-all preventive measure? Let's move toward precision prevention and look at the different categories of runners classified according to their foot posture. And we observed that motion control systems were effective in lowering injury risk among those with pronated feet, and it was not harmful among runners with other foot type. Another popular shoe feature is the heel-to-toe drop. This is the difference in thickness between the heel and the forefoot. In this study, we compared 3 different versions of the same standard running shoe, and the only difference between the 3 versions was the shoe drop, 10, 6, and 0 millimeters respectively. And we observed that in the whole cohort, shoe drop was not associated with injury risk. Again, let's move toward precision prevention and stratify our runners according to their profile. We observed that among the occasional runners, the rate at which the injury occurred was lower in those who received the low-drop shoe versions, in red on the graph. Conversely, among the regular runners, the rate at which the injury occurred was higher in those who received these low-drop shoe versions. So opposing effect of shoe drop on injury risk were observed in these 2 groups of runners. And what do we know about shoe cushioning? We recently conducted a large randomized trial to investigate the effect of shoe cushioning on injury risk. course, in this trial, the only difference between the two shoe versions investigated were shock absorption properties. We included more than 800 recreational runners in the study, and the distance they covered in the study shoes correspond to running around the earth more than 5 times. In the whole cohort, we observed that the risk of injury was lower in those who received the soft shoe version with greater cushioning. It is also common belief that heavier runners should use footwear with greater cushioning. So in this study, we investigate the association between shoe cushioning and injury risk among the heavier runners and among the lighter runners in two different analyses. On the left, you see that among the heavier runners, shoe cushioning was not associated with injury risk, while on the right, among the lighter runners, the risk of injury was lower in those who received the soft shoe version. So, is there enough evidence to support shoe prescription as a preventive measure? Unfortunately, I would say no, or not yet. There is a lack of high-quality RCTs, and the findings from this first set of trials have still to be confirmed. We recently demonstrated how cushioning may help prevent running-related injury, but some underlying mechanisms have yet to be uncovered. Researchers tend to seek for a global effect, with the difference between experimental groups or difference between shoe conditions, but every runner is unique and may react differently to specific shoe features, which would not translate into a group difference. And we should always keep in mind the real role of shoe features in the causal pathway. Indeed, athletes can only sustain a sports injury when they are doing sport. So the training-related characteristics should be the primary risk factors, while other factors like the equipment, the shoes, age, body mass index, or running experience can only modify the training load an athlete can tolerate before the development of an injury. And this illustration explains why precision prevention is absolutely needed in sports injury prevention. Let's say that among runners, we have 3 subpopulations depending on their running experience. So in this example, running 15 kilometers per week would be safe for population B, but for population A and C would be at high risk of injury because of their lack of experience. Then we may give them a general recommendation to decrease weekly distance to 10 kilometers per week. It will be appropriate for population A, but actually it is not needed for population B, and it will not be sufficient for population C. What does it mean? In research, when we implement preventive measure and we consider group characteristics as confounder, we get one single estimate for the whole population. So a similar estimate for all the subgroups, which is not sound. So we have to stratify a population to get specific estimate for each subgroup. Now I am doing a difficult stretching exercise to make the transition from sport injury prevention to physical activity for disease prevention. And actually, research in sports science has always benefited the general population. Like many technological innovations in Formula One are eventually implemented in our cars. And a very good example is the sport watches, which have been used by athletes for decades. Nowadays, the market of activity trackers is growing very rapidly, and our smartphones are also assessing our physical activity. And I also see an interesting transfer from research in sports injury prevention, where we try to determine the best training regimen at the right person, for the right person at the right moment before a competition or after an injury, to the field of physical activity for treatment and prevention of disease. But we have to recognize that the concept of precision prevention has not been largely developed in our field. For instance, there is strong evidence on the beneficial effect of exercise on insulin resistance, and we know that in a given population there will be good respondent and not respondent, but this inter-individual variability has hardly been investigated so far. And in our review, the authors identified some important gaps, such as the inter-individual variability due to the dose or the type of exercise, the possible psychological and environmental barriers to lifestyle change, or the identification of biomarkers of therapeutic effects of a specific exercise regimen. To move toward precision prevention, we have to properly describe physical activity. Here is the physical activity data of two people with exactly the same total energy expenditure. And you see in the red panel some peaks of high intensity and long period of sedentary behavior. While the white panel exhibit a more regular physical activity pattern. This shows that we lose much information when physical activity data is reduced to one single summary variable like total energy expenditure or time spent in moderate to vigorous physical activity. And more complex profile of the physical activity behavior are needed, as illustrated on the right. Actually, the American College of Sports Medicine has already suggested the FIT framework, where physical activity is described according to the frequency, the number of events per week, the intensity of the activities, the duration, or the type of activity. But this may not be enough. So we recently conducted a scoping review to identify the wearable-specific indicators of the physical activity behavior, which aim to capture the complex nature of physical activity behavior. And the main outcome of this scoping review is that the YPAP can be classified in three families. Those related to the distribution of the intensity, those related to distribution of the duration, so the way the activity accumulates over time, and those related to the regularity and temporal correlation of the acceleration signal. Another important outcome is that these YPAPs are quite new and have not been extensively used so far. To conclude, here are a few thoughts. First, of course, prospective designs are needed to generate knowledge on causal pathways and to test preventive measures. We should not oversimplify a complex reality. Wearable technology is interesting to collect objective data, but it's also interesting as it allows the collection of continuous data, which is absolutely needed to capture a complex nature of physical activity behavior and compute YPAPs, for example. It's also needed to investigate exposure that vary over time, like training exposure. And the choice of physical activity metrics should be based on the ability to reveal clinically relevant features of the physical activity behavior for a given population, as well as to discriminate between conditions or disease status. Thank you for your attention, and please note that the reference that I use in this presentation were listed in the last two slides. Thank you.